Thanks, Caroline, and thanks for everybody's statement today. Obviously, it's a very challenging time in regards to our health service, and a lot of people are kind of anxious in relation to what's going on at the moment. And some of us probably thought that, after the kind of very successful rollout of the vaccine program, that we would be in, the pandemic would have been our rear view mirror. Now that hasn't happened, because it's evolved, and this is a very unpredictable disease. And I think the credit goes to all the people that have put their shoulder to the wheel in relation to our health service. It's an incredible collective response to a pretty dire situation in relation to hospitals. And I know it's a cliche, but they are superheroes in relation to protecting everybody in this pretty bad situation. But again, we collectively will come through it, hopefully stronger in relation to our people and in relation to public health, because one thing that we've shown in the last 19 months is that there should be only one health service rather than two kind of parallel systems such as private and public. And that's not a kind of ideological thing to say. It is shown that where public health, one health system, national health service has better results for everybody in regards to your situation. Just from Mr. Reid, just a couple of questions. Is there a reason why the winter plan was late this year? Obviously, it's normally quite earlier. It's 7 weeks earlier. But is there any reason why it was later this year?
He's on mute.
On mute.
Apologies, Deputy Chair.
No problem.
So, Deputy, just 3 quick responses to you, if I can. Just first of all, thanks for your comments and recognising which, and all the deputies have, just a pressure on the health system overall. I mean, just to make a very simple point on this, the health system overall is a surge everywhere. That goes for GPs, that goes for our testing and tracing programme, it goes for our booster programme, it goes for our hospital staff, and it goes for our community staff. And we are doing this at a time where we now have 5,800 of our staff out with COVID-related, through COVID-related absence, which is just about 4% of our staff, along with a 4% absence of our staff, which happens anyway. So very significant challenges and pressures on our health system overall to stretch across all the demands that we have. But as you've said, our staff do that remarkably. Second thing, I just want to make a point, not a political point at all, I wouldn't, but I do agree the best use of public and private systems, particularly at a time like this. And we are strongly engaged with the private hospital system. We have been using about 1,100 beds per week. We do see that scaling up throughout the winter significantly for utilisation for, I guess, urgent care and non-COVID care, and potentially some elective care to keep that going too. Just finally, in terms of the winter plan, just to reassure yourself and the other Oireachtas members, it's not so much that it was late, sorry, it may be perceived as late in publication, but just to reassure, we had been acting and actioning many aspects of the winter plan, which were in our national service plan. So a lot of the issues around community actions to relieve the pressure on the hospital system were activated well before publication of it, because it was funded ahead of it. So I just want to reassure in terms of an perception we may be waiting for that.
Thank you. Just in relation to the breakdown of the winter plan, obviously it's 77 million, 26% of that would be going to private hospitals. Could you give a breakdown of where that money actually goes in relation to the winter plan? And just a second question that ties in with this in relation to surgical capacity in relation to the pandemic. And, last year, private hospitals were kind of, in some ways, kind of commandeered in some ways by the state. And obviously there is, where this situation is going, we don't know. So in relation to the safety net, in relation to public, the HSE contract with private hospitals, where are we at that? Are we a safety net 1 or safety net 2 in regards to capacity? So if you could answer then 2 questions, thanks.
Thank you, Deputy. On the winter plan, and again, I'll ask my colleagues just give some a little bit more on this, but very quickly for myself, on the winter plan, the use of private hospitals is exactly as I would have set out, that we will utilise it for supporting us in non-COVID care, supporting us in terms of potentially some elective care to keep that going, and particularly in terms of urgent care. We're also using some of ICU capacity. Right now, we're using about 8 ICU beds in the private hospital system, can go up to about 12, specifically in relation to where the winter plan funding will go. And then on your question around safety net, we're in safety net 2, which runs up to the middle of January, and we do expect between ourselves and the Department of Health to be engaged with the private hospitals in terms of an extension or revision, which will be part of those discussions. But I might just ask my colleagues, do you want to make a couple of comments?
So I think, Deputy, in terms of the breakdown of the plan, as Paul said, the plan was already, in a sense, parts of it being implemented as part of our National Service Plan for 2021. So the funding allocation is really for Q1 next year. We weren't seeking additional supplementary funding for Q4 this year. We're continuing to implement our service plan. So the additional funding from Q1 next year allows us to maintain an arrangement with the private hospitals, as you said, also to maintain our increased level of transitional care beds. We do have 30 million in our base for transitional care. This gives an extra 20 million to keep going at the rate that we've been going at this year. It also provides for initiatives in terms of front door initiatives within hospitals, for our emergency departments, enhanced liaison in respect of mental health, also some of our other discharge options. So, for example, there's funding in there for our disability services in terms of people with very complex needs who need to be discharged from acute hospitals. So it is the range of things, including, for example, aids and appliances, that we would, if we look back, we'll see those in every winter plan. But in reality, what the winter plan funding allows us to do is to accelerate certain initiatives that will appear also in our National Service Plan for next year. So it gives us the go-ahead in relation to 77 million to start now for Q1 next year.
And just one final question, just in regards to ICU capacity, and obviously the situation at the moment, there's over 135, I think, people in ICU in relation to ICU capacity. At the moment, I think Ireland has 300 ICU beds. If the situation deteriorates, which we all hope it doesn't, where could the other capacity come from? If the situation really goes beyond, where the projections happens, where is that capacity? Is there capacity in relation to the private hospitals? Because my understanding, private hospitals ICU capacity would be relatively limited. So where, if the situation deteriorates, where could we get that capacity? Because if and again, hope we never this happens, but if the situation was projected at the worst kind of projections, I mean, it's pretty dire, because it would go up to 400 to 500 people in ICU. Now, if we don't have that capacity, then obviously hard decisions are being made. So in that scenario, where does the ICU capacity come from?
Chair, I might just ask my colleague, Dr. Colin Henry, to respond to that one.
Take it on mute.
Unmute.
Just 1 second, we'll unmute Colin.
Hammer and chisel.
Sorry, Doctor. Thank you. As you say, none of us want this.
The sound is very poor.
We
Yes.
can't hear him. You might ask him to put his mic down.
You can hear me?
Headset.
The mic has to be down. Chair,
Down mic.
Yeah.
Can you hear me?
Yeah.
That's great. Yeah, good.
Sorry, Deputy. Yeah, as you say, none of us want this to play out. It's certainly uncontrolled admissions to ICU are much harder to manage than preventing people getting sick in the first place. So that's absolutely true. We worked with the critical care community closely, particularly in the last surge, to identify additional bed capacity outside conventional intensive care units where we could provide temporary designated ICU care. That was much dependent on redeployment of staff, on training up of staff who don't normally work in ICUs, and of identifying areas contiguous to ICUs such as anaesthetic rooms, theatre rooms and the like. And during the surge in January, we went up from our then base of about 279 ICU beds to a peak including COVID and non-COVID patients, of about 340. So like we're going through the same exercise, Deputy, on this occasion, where we're going to the hospital groups, the managers of each hospital and the critical care community who are critical to this in seeing what additional bed capacity we can provide and maintain the same outcomes of care, because that's the critical thing here. We were able to say that we could go up to 350 beds and maintain good outcomes of care, which our figures now show that despite all the pressures we were under in the successive surges since March 2020, we maintained outcomes which are comparable to other European countries. So we were finalising the latest exercise with the critical care community today. We expect we should be able to get up to at least a surge capacity of 350, including, as I said, temporarily designated spaces using staff redeployed from other areas. But that's the big condition here, Deputy, is it doesn't come without a price, and the price is redeploying staff who are trained in this and also providing care outside of traditional units.
Thank you.